The webinar will begin shortly. Please remain on the line. The broadcast is now starting. All attendees are in listen-only mode.
So, good afternoon and welcome everybody to this webinar on lactate use in clinical practice, organized by the European Society of Intensive Care Medicine. There has been some confusion about the correct time that this webinar will start, which was due to the fact that our today's speaker is located overseas and also because of the change to the summertime. Sorry for this confusion, but I hope everyone made it in time and you are not angry about this. So my name is Thomas Scheren and I'm a professor of anesthesiology and intensive care at the University Medical Center in Groningen, which is in the Netherlands. And I'm also chair of the cardiovascular dynamics section of the ESICM. I will be moderating this webinar. During the session, if you have any question, you can pose it in the box and we will come back to it at the end after the talk, or if it's very, very important question, I might also ask the speaker to answer it immediately. So, speaking about the speaker, today I would also like to welcome Professor Jan Bakker, who is a great expert in the field and has a large track record on the topics related to lactate. Recently, the Andromeda shock trial has been published in JAMA by his group, and I think we will hear more about this later. Professor Bakker is currently working at Columbia University in New York, but also at Erasmus University in Rotterdam and in Chile. Furthermore, he is the deputy chair of the cardiovascular dynamics section of the ESICM. So welcome, Jan, and may I hand over the microphone to give us your talk, please.
Yes, thank you, Thomas, for the introduction, and good morning for me, good afternoon to the others. We're going to spend some time on how lactate can guide resuscitation. And that's an important topic because especially in the surviving sepsis guideline, there are not many other guidelines that include lactate, but surviving sepsis guideline has a very prominent place for not only measuring lactate, but also recommending a targeted change over time. And that's a very important parameter, the measurement of lactate, as for instance in the United States, if you don't comply with those parameters, you're not paid for treating the patient. So there's a very a negative incentive if you don't comply to the guideline. And so lactate is in, let's say, the center of the resuscitation. But actually, I'm afraid it's a little bit more complicated than suggested. For this presentation, we have no conflict of interest. There are some companies now that are working on a more or less continuous lactate measurement device, where you have, let's say, every 5 to 10 minutes, a new lactate. We will come back to that in when we talk about delta lactate over time. Now, the interesting thing about lactate is when it was first described in 1845 by a German physicist, it was measured in patients that had just died of what we now would call septic shock. And those lactate levels were very high. And ever since that very first description, up until 2 days ago, when a paper came out about delta lactates and predictive value of lactate, ever since that time, lactate has always been associated with a worse outcome. And so if you have a patient with more or less a similar condition than the other patient, and one has increased lactate and the other one has not, the one without the lactate has always a better prognosis than the one with increased lactate. And to make it simple, this is a study done by the group in Santiago, Glenn Hernandez. And what they did is they selected patients with septic shock. And so patients with fever, likely infection, and hypotension, they gave an initial fluid resuscitation. The hypotension did not go away, and so they required the use of vasopressors, and so the classical definition of septic shock. And then they looked at patients that had a lactate above 2.5 or less than 2.5, and you can appreciate in the slide the huge difference in mortality between these two groups. So probably we would now say that the hypotension in the sepsis group without the lactate is possibly infection-related hypotension, but not septic shock. And the sepsis 3 definitions, you now have to have increased lactate levels. Whereas the increased lactate levels with hypotension would be septic shock, and we all know mortality of septic shock is way worse than the mortality of sepsis-related hypotension. And that's basically what they show. And lactate in this group could clearly help you to discriminate the two groups. And in another recent study from Australia, they looked at patients with hyperlactatemia, so only high lactate, and patients with hypotension that did not respond to fluids. And the hypotension was defined as low systolic blood pressure or low mean arterial pressure that did not respond to a fluid challenge of at least a liter within 1 hour. And lactate was used as 4.0. That's the old surviving sepsis guideline definition of severe sepsis. And so what they did is they looked at patients with refractory hypotension, no lactate, and patients with lactate and no hypotension. And so you have isolated hypotension, 850 patients, isolated hyperlactatemia, also a large number of patients, almost 500. And then when you look at 90-day mortality, the mortality in hypotensive patients without lactate is 12%. The patient with lactate but no hypotension is almost double. And then it's very clear that if you have lactate for whatever reason, you're in a worse condition than when you have no lactate, even if you have very abnormal vital signs like, for instance, hypotension. And so the next question is, okay, that's a given lactate when you come in. What about the changes in lactate? This is a recent study where Jean-Louis Vincent from Brussels collected all the literature in which they at least measured lactate twice. And he came up with 96 studies in almost every field of critically ill patients that we see in our units. And so they found publications about general ICU populations, surgical patients, post-cardiac surgery patients, trauma patients, sepsis, cardiogenic shock, cardiac arrest, respiratory failure, and that almost covers your whole mix of ICU patients. And of course, you have different scenarios. So you have the best scenario is that you immediately start decreasing the lactate level over time, and within a given period come to an immediate normal lactate level. But some, and I think you all have this experience, you start treating the patient, and instead of decreasing a lactate goes up or doesn't change. That's a bad sign. And if you decrease lactate, then at some point it can stall for a while. So do not change much, and then it starts to decrease more, or it can even start to increase again. And all these scenarios that differ from a steady decrease to normalization, all these scenarios where you do not come to, let's say, normalization within a reasonable time. Usually we take 24 hours. I will come back to that later. But all these scenarios have a worse prognosis. And in this study, he showed that with the current evidence from these 96 studies, the reasonable time to remeasure lactate after you've taken your first measurement is about 2 to 4 hours, 1 to 2 hours. The recommendation by the Surviving Sepsis guideline is to measure lactate every 2 to 4 hours. So that's double the time that comes from this study by Jean-Louis Vincent. And so, if measured every 1 to 2 hours, your lactate decreases, that's good. If after the first hour or the first 2 hours, your lactate has not changed or increased, something is wrong with your patient. And you should reconsider what you are doing. I will come back at the very end to give some practical guidelines. Now, the question is, do we know what to do when you come in with an increased lactate? Well, this is what we studied in this study published a few years ago, multi-center randomized study in the Netherlands. 4 centers were participating. We randomized around 400 patients, and we said, okay, in the very first hours of patients that come in with an increased lactate, we took 3.0 as a cutoff point. And in these patients, you do not have any suspicion that something else than circulatory failure is going on. For instance, if you have a patient with metformin and diabetes and increased lactate, there is a reasonable chance that the patient is not in shock. The most easiest example is patients with seizures. Patients with seizures, by definition, generate lactate, but they're not in shock. But if you think, okay, this lactate could be due to circulatory failure, I will come back later on at the end on how to do that. Then we randomized to patients where we measured an SCVO2, so the hemoglobin saturation in the vena cava superior, less than 70% or more than 70%. And the more than 70% is a marker of high flow or a distribution problem, a microcirculatory perfusion problem. And at that time we said, okay, if the microcirculation is deranged, so you have shunting in your microcirculation, or a microcirculation is not opened up, and you get mixture of very high saturations, then in that case we use vasodilators. And so if you came in with lactate and a high SCVO2, we made sure that your blood pressure was at least 60 with norepinephrine, and then we started a vasodilator. That's a small number of patients that come in at the very first entry into the ICU. This study started immediately on admission to the ICU. It's a very small number that come in almost completely resuscitated, but having a microcirculatory problem only. The majority of your patients, when you first see them in the first hours of septic shock, will have a low SCVO2, as was the case in the RIVER study and was the case in our patients. And so we said, if you have increased lactate, you think there is no other cause than circulatory dysfunction, your SCVO2 is low, then you have a problem in the match between the oxygen demand of the patient, of the tissues, the organs, and the oxygen delivery. So that's what you should target. And how do you target the mismatch between demand and supply? That is, decrease your demand. And so we were rigorous on treating pain, analgesia, in patients that were uncomfortable and moving around. We were easy on sedatives. If the sedatives caused respiratory depression, we put the patient on a ventilator, which gives you an additional decrease in oxygen demand. We were treating very high fevers if necessary, and if it was malignant hyperthermia, we did cooling, or hyperthermia, let's say more than 40 degrees, we did cooling. This was done in a very small number of patients, but this was a very prominent element of the manipulation of increased oxygen demand. The other element of the mismatch is improving oxygen delivery. So we had a target hemoglobin level based on the studies at that time. We had a minimal saturation, and so this made sure that we had adequate oxygen content. And then we had fluid responsiveness. Patients, and if they were fluid responsive, we said it's hypovolemia. The terminology is completely wrong because it's not really hypovolemia. It's what we would call relative hypovolemia. But if you had these conditions and you were fluid responsive, we gave fluids to try to solve the problem. If you were not fluid responsive, then we try to increase cardiac function to increase cardiac output. And for that, we usually used dobutamine or inoximab in these patients. And the aim was to increase SaVO2 to more than 70%. And that was the goal in the protocol group, to decrease your lactate. So the objective of the study was, by doing all of this, maintaining a minimal blood pressure of at least 60, by manipulating oxygen demand, by improving oxygen delivery, and improving microcirculatory perfusion, that we should decrease lactate every 2 hours by 20%. But very important, we only did this for the first 8 hours of admission. I will come back to that later. Why? So for 8 hours, so 4 measurements of lactate every 2 hours, the lactate had to decrease by 20%. If not, then we reiterated this analysis, reiterated the diagnosis, reiterated the therapy. And so what we, in a few patients, found is this was optimized, but lactate did not decrease. And then we talked to the surgeon because we thought it was an abdominal problem. We convinced the surgeons to go to the OR, or first we did a CT scan, went to the OR and found a small abscess that we couldn't find by physical exam. At that time, we didn't do POCUS, point of care ultrasound, which would by now probably be incorporated in protocols like this, especially in the emergency room. And so every 2 hours we had to check on, is the therapy adequate or do we miss something? And that's coming back to this study. So whenever this happened, we were reconsidering what's going on here. As long as the patient went this, we continued, but every time something like this happened, we reconsidered. And that for 8 hours. And we showed in this study that the mortality, ICU mortality and hospital mortality, when we corrected for baseline abnormalities, that the mortality in the lactate targeted group was 8% lower, a 20% relative reduction in hospital mortality. When together with Wan Yi from China, I did a sequential analysis of 4 trials in 2015 that were available at that time. And we looked at the 4 studies that incorporated lactate as a target of resuscitation. And we found that in those 4 studies, and we took only sepsis in these patients, the lactate study included every patient with an increased lactate. But when you look at sepsis, that was indeed a favorable outcome when you targeted lactate in patients with sepsis. And so this is where the recommendation of the Surviving Sepsis campaign comes from. And when they quote that you should target lactate, they usually refer to the Tim Janssen study. Now, I said we targeted lactate for 8 hours. And the reason was that we suspected that in the initial hours of lactate is the consequence of abnormal tissue perfusion. Some say tissue hypoxia. I think there is a lot to say of whether tissue hypoxia is really present, but tissue perfusion, yes. And so we said we target tissue perfusion in the first 8 hours because it's extremely likely from all the experimental studies I did myself and others did, that in these early hours of sepsis you have hypoperfusion of the tissues and organs. Later on, we tested this hypothesis because we had no time to do it in the time of the lactate study. And so together with Glenn Hernandez, we looked at patients with septic shock, increased lactate levels, and we only took the survivors. So in surviving patients of septic shock, we looked at normalization of lactate, and that's what you see here. This is, let's say, the INR of lactate. And as you can appreciate in this graph, is that in the first 6 hours of these patients, the normalization was steep. There was a very fast number of patients normalizing their lactate. And then for the next 18 hours, the number of patients that normalized their lactate was very low. And at this point, almost half of the patients still had somewhat increased lactate. And so this is complicit with the time frame of the lactate study. Here you should target tissue perfusion. Is that true? Well, when we look at other parameters of tissue perfusion, you see exactly the same. So the delta PCO2, the difference between the central venous CO2 and the arterial CO2, which should be less than 6 millimeters of mercury. And if it's higher, it's indicative of abnormal tissue perfusion. If you look at this parameter, you see exactly the same. You see a very rapid normalization of the delta PCO2 in patients, just like lactate. And then for the next 18 hours, it trendles off, and a very small number of surviving patients still improve their delta PCO2. When we look at capillary refill time, which was the target parameter in the Andromeda study that I will present later, you see exactly the same. So whether you use a parameter of cardiac index, because that's what the delta PCO2 is, or a more somewhat subjective parameter that you can measure in any circumstance. You don't need central lines, you don't need arterial lines. You just have to press the finger and measure the capillary refill time. You see exactly the same. So a very steep increase in the patients normalizing the capillary refill time, a very steep increase in the number of patients improving their delta PCO2 or normalizing their delta PCO2, and this steep improvement in tissue perfusion is met by a steep number of patients normalizing their lactate levels. And so from this study, and this is the only study still available, it is clear that there is some kind of biphasic relationship in time and lactate levels. And so the question is whether you should indeed use tissue perfusion interventions beyond 6 hours. At least in this study, there is no support for that. In another study, we said, okay, let's look at lactate and let's see whether increased lactate in the presence of parameters of tissue hypoperfusion has a different outcome perspective for patients than when they don't have it. And it's basically, if you go back, you go basically back to this group versus this group. And so what we did is we studied patients that had a hypoperfusion context, and we said hypoperfusion context is a low SCVO2, increased delta PCO2, or an abnormal capillary refill time, because these are all parameters of tissue perfusion. And so if you had lactate and you had any of these parameters being abnormal, or you had lactate but all these parameters were normal, we looked at outcome. And of course, the hypoperfusion had different parameters than the non-hypoperfusion, because that was the selection. So if you had lactate in the context of a parameter that is indicative of hypoperfusion, you needed much more norepinephrine, not only in the very first hours, but also 6 hours later and still at 24 hours. But most importantly, your mortality was higher. This was not significant. It's a very small group of patients, but you were on the ventilator for more days. You stayed in the ICU longer, and you had more rescue therapy. What they do in Santiago is, if a patient doesn't respond to the initial treatment, so vasopressors, antibiotics, fluids, dobutamine, or whatever you want to increase cardiac output, and the patient does not clearly improve, they do the high volume hemofiltration. And they do it as a rescue therapy. And so you can see, although the differences are not significant, that in all these, let's say, secondary outcomes, except for, and let's say, organ function related outcomes, these patients with hypoperfusion and lactate do worse than patients with lactate without hypoperfusion. And so, in conclusion of this part, you can say, in the early hours, if you have indications of hypoperfusion, in the lactate study, we only used SCVO2, but in this study, we also used capillary refill time or your delta PCO2. Then those patients are the worst. They have the worst prognosis. And in the lactate study, we showed that if you target this hypoperfusion with either fluids or improving cardiac output, or maybe even, if you're bold, using nitroglycerin to improve the microcirculation, that the outcome of these patients is improved. Now the question is, okay, this is clear. This is probably hypoperfusion, and we have very, let's say, efficient interventions that can deal with these problems to improve delta PCO2 and improve perfusion of organs. So the question is, as 50% of the patients that survived still had an increased lactate at 24 hours, what's going on here? Because if this is not really overt tissue hypoperfusion, what's going on? And more importantly, what is the information you as a clinician would get from this, let's say, not that fast decreasing lactate? Well, one of the elements is impaired lactate clearance. And clearance here in this study that we did in the sheep model of septic shock is real clearance. So what we did is we injected lactate and then injected lactate and then measured the amount of lactate that disappeared over time. So that's the real lactate clearance. In the literature, lactate clearance is usually referred to as the difference between two measurements in time expressed as a percentage. So you measure on admission, you measure 2 hours later, and the change over these 2 hours is defined as clearance. That's not really clearance, because clearance in pharmacodynamics is, of course, the disappearance of a substance from the blood in this case. Now, what we showed in this very severe model of septic shock, the animals needed a lot of vasopressors to keep them stable, because it was a continuous infusion of endotoxin. As you can see, there is continuously endotoxin being infused in these animals. That makes them very sick. The lactate levels went to sky high. In many sheep, more than 9 to 10. So a very severe model of septic shock. And what you can appreciate is, here is the lactate clearance. This is baseline. And so at baseline, the sheep clear 1,000 milliliters per minute of lactate. So they clear 1,000 milliliters. That's a liter per minute of blood from lactate. And what you can appreciate here is immediately after septic shock, it's close to zero. And so in these early phases of animal septic shock, this is not what we have been able to measure in patients yet. But in these animals, there is absolutely a problem in the liver to deal with lactate. Not with sorbitol. Sorbitol is an alcohol sugar, and we did the same thing with sorbitol. And the liver is completely capable of metabolizing sorbitol, which is taken up by the liver and excreted in the bile. It has a very high first pass effect, so the liver is extremely efficient in removing sorbitol from the circulation, either in sepsis or not in sepsis. And this is not related to hepatic blood flow that we measure. We measure total hepatic blood flow. There was no change. So this is a real function abnormality of the liver, this lactate clearance. And so you can imagine that if you remove the first generator of lactate, the hypoperfusion context, then you're left with an element of abnormal clearance where lactate levels may not change at all, where perfusion is completely normal. And so at that time, and that's how I use it in clinical practice now, after 6 to 8 hours, I don't, if I have resuscitated the patient well, I come back at the end on how to use that in clinical practice, then I see lactate more as an indicator of something is wrong. And something is wrong can be metabolism, can be generation, but doesn't necessarily have to be septic shock. And here I have two, let's say, extreme examples of that. On the left is a patient with Hodgkin, with lymphoma. And we know that lymphoma has Warburg glucose metabolism. And so they mainly metabolize glucose, have no mitochondria, and so they push out a lot of lactate. And so this patient comes in, is diagnosed immediately with lymphoma, and develops ARDS, and is admitted to the ICU. He did not have chemotherapy yet. And so he came to the ICU, the diagnosis was already clear, we stabilized the patient, and then we started his first chemotherapy in the ICU. And this is the LDH. As you know, LDH is a marker of lymphoma, and the levels are extremely high. So this is 60, 50, 40,000. And due to the chemotherapy, this tumor was very sensitive to chemotherapy. You can see that the LDH decreases rapidly to levels less than 10,000. At the same time, he had lactate levels of 10. He was not in shock. He only had lymphoma and ARDS, but had no circulatory dysfunction. Maybe a little bit in the beginning, but we resuscitated him and optimized circulation. But his lactate levels never fell below 6, and even rose after we did the initial treatment. And at time of the start of chemotherapy, it was around 9. And as you can appreciate, together with the fall in LDH, his lactate level rapidly normalized to less than 2. And interestingly, on this day, his lactate level started to increase already before his LDH. So his LDH started to increase about here. At that time, his lactate level was back to 10. And so the indicator of recovering lymphoma cells was not LDH, but was lactate. This is metabolism. This is not shock. This is metabolism. And his lactate increased to 18 when he got his second chemotherapy, and the same thing happened. His LDH rapidly fell, and his lactate rapidly fell to 2. So here, lactate is an indicator of abnormal metabolism. The same over here. This was a patient with diabetes, and the patient had a stable circulation. He had a drain in an abscess that was not functioning very well. We told the nurses to drain, flush the abscess with at least half a liter to a liter of fluids until the fluid that came back was clear. But in the weekends, the nurses were afraid to do it because there was resistance, and sometimes the drain didn't function at all and they didn't rinse. And what you can see is that whenever the drain was malfunctioning, his lactate rapidly increased to 6, 10, together with a small increase in glucose. His glucose never was more than 11 millimoles per liter, but every time he had a surge in glucose, he had a surge in lactate. Here, 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 and here. And we tested his mitochondrial function. There was no abnormality in mitochondrial function, so this is not what Mervyn Singer from London is studying, mitochondrial dysfunction in sepsis, because we couldn't find any abnormality. The only thing we found was his abnormal glucose metabolism because of his diabetes. And so here the increases in lactates were indicative of inadequate control of the infection, inadequate source control. And so every time his lactate bumped up, we went back to the abscess and the drain and made sure the drain was open, rinsed the abscess, and then lactate would come down. And so that's, I think, a very important element of lactate as well. It's indicative of something is wrong, or maybe you're not adequately treating the patient. And so, as I said, we first did a lactate study, targeted tissue perfusion. Then we found that any parameter of tissue perfusion is a bad sign when you have lactate, including a very simple one, the capillary refill time. And so we said, let's compare the two. Let's randomize one group to lactate-targeted resuscitation, basically the standard of care now in septic shock, and in the other group, use the simple parameter of capillary refill time. And so that's what we recently reported in JAMA, the effect of a resuscitation strategy targeting peripheral perfusion using capillary refill time or lactate. And the objective for lactate was the same as in the Janssen study, so 20% decrease every 2 hours for the first 8 hours. The target for peripheral perfusion was normalizing capillary refill time to less than 3 seconds, which is a completely normal capillary refill time. And what we did in this study is we incorporated basically all recommendations that are now either more hidden in guidelines or clearly expressed in guidelines, and mainly as suggestions. And so we said, let's try to operationalize these recommendations into the protocol. And so the protocol was similar in both groups. We used the same protocol in both groups. And so either you had an abnormal capillary refill time or you had an abnormal lactate. And if the answer was no, if you already, your first resuscitation after 2 hours normalized your lactate or your capillary refill time, then you were done. And you would follow lactate for the 8 hours of the study. We again used 8 hours. So every 2 hours you would reiterate this question: is capillary refill time still normal? Is lactate still decreasing? Yes, then don't do anything, wait and see. In the capillary refill time, we used frequent assessments because capillary refill time responds very fast. You can easily assess capillary refill time every 30 minutes. For lactate, we used a recommendation from both the study from Jean-Louis Vincent and the study we did every 2 hours. And then what we did, first resolve fluid responsiveness, just like we did in the lactate study. In patients with chronic hypotension, if you didn't meet the target, then we did a vasopressor test. If you had chronic hypotension, we increased blood pressure to 80 to 85, which is, let's say, the result from the study from France. If the patient responded, then we kept the high blood pressure. If the patient did not respond, then we did an inodilator test and we used dobutamine or milrinone, whatever you wanted, to get lactate to decrease or normalize capillary refill time. If you had no chronic hypotension, you went immediately to the inodilator test after you had become fluid unresponsive. And anytime you didn't meet the goals, you went back. When you met the goals, you went back every 2 hours or 30 minutes in lactate and reiterated this to make sure that the goals were met for the full 8 hours of the study. And what we showed in this study is that that there was an improvement in survival. The p-value was 0.06 between the two groups, but the patient with the capillary refill time guided resuscitation did better. They also had a faster decrease in lactate levels, to our surprise. They also had a faster decrease in SOFA. And so secondary endpoints were better in the capillary refill time group when compared to lactate. And also, and that's what we expected, they used less fluids in the capillary refill time group. So in this study, it seemed that peripheral perfusion is even better than using lactate levels. So how to incorporate all of this into clinical practice? Now, this is what we published recently in Intensive Care Medicine. You have an abnormal lactate level. And if you think that there is a probable cause that this is not tissue perfusion, so for instance, seizures or metformin or any other intoxication, or you have a lymphoma, then, and you think, yeah, that could very well be, then act accordingly. Don't give fluids to a lymphoma patient. That won't decrease his cardiac, that won't decrease his lactate or improve his capillary refill time. Most patients with seizures don't need fluid resuscitation. But if you think that lactate is associated with tissue hypoperfusion, so there is no reasonable other cause, then look at peripheral perfusion. And you can use capillary refill time, you can feel the temperature of the skin, you can use the discoloration of the skin, the mottling. In the Andromeda, we use capillary refill time, but every parameter is appropriate. If you have normal peripheral perfusion in the presence of increased lactate, and you have normal SCVO2, that's the second step, then we would advise you to measure the delta PCO2. If the delta PCO2 is also normal, So you have lactate with normal peripheral perfusion, normal SCVO2, normal delta PCO2. Remember the study on the hypoperfusion context. Then probably something is wrong, but not tissue perfusion. And so probably your assessment over here was not that accurate. And you have to rethink, because there is no real hypoperfusion in these patients. So remeasure lactate, make sure you have source control, make sure you have not another diagnosis and stuff like that. If you have an abnormal delta PCO2, then you have tissue hypoperfusion in the presence of normal SCVO2 and normal peripheral perfusion. That's rare, but it happens. And so you have another indicator of hypoperfusion, so treat accordingly. Increase cardiac output in these patients. And then the lactate should fall, and then you observe. If the lactate doesn't fall, then maybe you have again another source of your lactate. If peripheral perfusion or SCVO2 or even both are abnormal or low, you have tissue hypoperfusion. You should increase tissue blood flow with dobutamine fluids or whatever you want. Lactate should decrease, and I've hardly ever seen a patient that does not decrease his lactate levels in these cases. And then you observe. If lactate doesn't change, then make sure that you have a normal delta PCO2, because again, something else is going wrong. If you have increased or normalized SCVO2, but lactate doesn't change over time, make sure your delta PCO2 is also normal. If not, increase blood flow further to make sure lactate decreases. If lactate doesn't change after you normalized everything, again, reassess the patient if you miss something. And so the complete picture is this. You start with, do you think something else is going on? No. If you have tissue perfusion, you start with the simple stuff, peripheral perfusion, SCVO2, delta PCO2, and take it from there. And if any of these is abnormal, you have hypoperfusion that we very adequately can measure and manipulate with fluids, dobutamine, inoximone, and all the other interventions that we have. So to conclude, lactate is a very strong predictor of outcome, just like changes in lactate. Therapeutic intervention that aim to decrease lactate by 20% every 2 hours for only the first 8 hours of ICU admission, both in sepsis and in patients without sepsis, are associated with improved outcome. And the early phase of decreases in lactate seem to correlate much more with tissue perfusion than anything else. And if you use capillary refill time in the latest study that we published, you're at least as effective as when you use lactate. So if you have a problem getting lactate very fast, then you can easily switch to capillary refill time to resuscitate your patient. Thank you very much.
Thank you very much, Jan, for this excellent presentation, and congratulations to the results of the Andromeda shock trial. And also, I was very impressed about this complex but very well-designed algorithm that you just presented to us, how to diagnose and follow the patient in shock on lactate and PCO2 gap. So we have a few minutes for questions, and if I just look at the questions, we can start with the first one. Do we need to include hypoxemia in the definition definition of shock or definition of lactate? You mentioned this in the, yes, of course, in the Janssen study.
Well, that's an interesting study because we know from animal experiments that if you decrease oxygen delivery is cardiac output, so this part of the resuscitation, and saturation and hemoglobin. If you only decrease saturation, so PaO2, and keep this normal and this normal, then ultimately these animals will start to generate lactate. There is no discussion. But in clinical practice, what happens, if you become hypoxemic, so low PaO2, low saturation, in the majority of your patients, if cardiac function is normal, you will increase your cardiac output. And even if you remember the study those crazy Englishmen did on the top of the Himalaya, where they had PaO2s of extremely low values, they hardly had any lactate. And so only saturation, only low PaO2 is a very unlikely cause of hyperlactatemia. And so we had a huge discussion, what level should we use in this study? I wanted to use 85%, but many were uncomfortable. And so this was a consensus number. Let's do 92%. But in the majority of your patients with very low saturation, something is wrong with myocardial function. And that's why they cannot compensate. And so the main problem is the heart failure and not the low saturation.
Yeah, thank you. This is a very good example from these Himalaya guys, that low oxygenation or hypoxia per se does not necessarily lead to an increase in lactate. The second question that we have is there any relation between lactate level and the PCO2 gap that you also mentioned? So there's difference between venous and arterial PCO2 levels. Are there any correlations which can help to optimize hemodynamic treatment?
Well, the only study we have in patients is this one. And so if you increase the delta PCO2 in a shark model in animals, and the only way to do that is by decreasing cardiac output. And so we published a study on tamponade and sepsis, then your delta PCO2 will increase rapidly. If you then increase the cardiac output again, either by decreasing tamponade or taking away the tamponade, or increasing the cardiac output with fluids, your delta PCO2 will rapidly normalize and your lactate will start to decrease again. We did a tamponade model with hypozang, and you get a clear, very close correlation between the two. And so delta PCO2 increases, lactate increases, you resuscitate, delta PCO2 goes to normal, and lactate goes to normal. In patients, this is the only one we have. The interventions to manipulate delta PCO2 are basically manipulating cardiac output. And so that's fluids, dobutamine, or we love the phosphodiesterase inhibitors. So anything that increases your cardiac output. And I think there you have the main interventions to target your delta PCO2.
Excellent, thank you. The next question is, so you mentioned high lactate levels in your animal studies, but also in those lymphoma patient. But in septic shock, how frequent do you see a lactate level above 10, let's say, in septic shock patients in your clinical practice?
Well, there are two studies in the literature that looked at the very high lactate levels of 10 or more. And if I recall well, the incidence is around 3%. So about 3% of the patients come in with a lactate level of more than 10. The mortality of these patients is in one study more than 60%, I think 65. And the other I don't recall. I just reviewed a study where they had again an incidence of about 3% and the same mortality numbers. And so it's very infrequent, but the mortality is very high. It's no reason at all to stop treatment. When we did the lactate study, we did a small observational study, retrospective, to see what kind of numbers do we get in our institution. It was very low, these high lactate numbers. In the control group of the lactate study, the number was also very low, but no one survived. No patient with a lactate more than 10 in the context of circulatory shock survived in the lactate group. So when you start to treat lactate, there was an absolute 30% mortality difference. So 70% of the patient died. So 30% survived. And so there is no reason to not treat patients in shock with a lactate of 10. But even when you adequately target lactate, mortality is still around 70%. So huge mortality.
Okay, excellent. Thanks. Next question. Can we use lactate as a biomarker in patients on ECMO when we try to wean those patients? Can we rely on lactate?
That's a very good question. That's what we frequently do, to be honest. Currently, ECMO flow and LVAD flow, for instance, is targeted on SCVO2 or SVO2 and lactate. But as I said, lactate is slow. Although in the study that's now on the screen, it seems as if there is a rapid decrease in lactate levels. That's 6 hours. And if you wean someone from ECMO, you don't want to wait for 6 hours to see whether he does okay or not. And so I think lactate, it's what we have, but is it optimal? No. If lactate increases, if you try to wean from ECMO, stop doing it, that won't work. So that's a very strong signal. We published a few studies where we looked at the microcirculation. And indeed, if you decrease ECMO flow and try to wean someone and the microcirculation deteriorates, that's a bad sign. You cannot wean these patients. And that's, of course, a very rapid response. Lactate is slower. But if you decrease ECMO flow and 2 hours or an hour later you measure lactate and it has increased, stop doing it. That won't work.
You mentioned in the beginning that there are no continuous lactate measurement devices available based on microdialysis or whatever. Would these be helpful in those cases to guide?
Well, that's an interesting point, because you would expect, especially in these ECMO patients, that if you measure 2 hours later and it has increased, that the increase didn't occur the last 15 minutes. So you might expect a steadily increase in lactate in those, let's say, first 60 minutes. The problem is we have no data, so we don't know. So these companies now sell the device as this is much better than we had before because you have more frequent lactate levels. But clinically, we have no clue what to do with these lactate levels, and they could very well be harmful because we react to something that should not be reacted upon. But in the case of ECMO, I mean, intuitively, I would say yes. If you see these lactate steadily increase every 5-10 minutes, that's probably not a good sign.
Okay, thank you. So looking at this picture, which is still on the screen, we see this 6 hour frame which you stressed, where the lactate is decreasing, and also the other biomarkers. But these were patients with septic shock, as far as I remember. And the question is, could this be translated to, let's say, patients in cardiogenic shock, or do they have a different kinetic profile?
Yeah, that's an excellent question. We don't know. From the study that Jean-Louis Vincent pulled together, the overall, let's say, picture of lactate is not different in the different groups. So if lactate doesn't decrease in your cardiogenic shock patient, that's a bad sign. If lactate increases in your cardiogenic shock patient, it's a bad sign. The exact time relationship of lactate in cardiogenic shock versus sepsis is unknown. But as you know, the early hours of cardiogenic shock is a flow problem, and then almost every cardiogenic goes into a more sepsis-like profile. They get organ dysfunction, they get metabolism abnormalities. And so probably later on in cardiogenic shock, it's not very much different. As the group from Brussels already showed many, many years ago, every patient that dies in cardiogenic shock ultimately dies with a completely normal cardiac output and has a more sepsis profile than cardiogenic shock profile. The question is intriguing. The overall message is still the same, but the actual time resolution, we don't know.
Excellent, thanks. So you mentioned the PCO2 gap, but we could also, to make it a little bit more complex, not only look at the PCO2 gap, but at the ratio between the PCO2 gap over the arterial to venous oxygen content difference. It's sort of a respiratory quotient.
Yep.
And this way identify ongoing anaerobic metabolism in sepsis and determine the prognosis. What are your thoughts about this?
Well, that's data published by the group from Brussels and mainly Gustavo Ospina-Tascon from Colombia did a lot of work on this. And I think it works. And I use it sometimes in patients. But after 6 hours, and at least in my limited experience, because not a lot of patients still have these problems. After 6 hours, yeah, you get this profile that you have increased lactate with an abnormal respiratory quotient that is not compatible with anaerobic metabolism. And then it more or less underlines the fact that something else is going on than tissue hypoxia. We didn't incorporate it into the flow chart and the algorithm at the end because it would become extremely complicated. And so we started off with simple, but if at the end of the day you come, lactate doesn't change, there's something else going wrong, I always calculate this quotient to make sure I don't miss anything. Yeah, good question.
So a valuable addition. Thank you. The next question is on the capillary refill time you also mentioned. So compared to the lactate measurements, which is a solid lab measurement, isn't the capillary refill time more operator dependent? You could imagine the one operator presses harder than the other or longer than the other. So does this play a role in how reliable are these values if we compare it across the literature?
Yeah, that's a key question in this research. And that's also the reason that we try to have as little inter-rater variability as possible. So we went out to all the units that participated in the Andromeda study to train them. We used a glass to press on the skin, so you could actually have a good visual image of the skin. And we used a stopwatch to decrease. If you tell an untrained person, can you please do capillary refill time, and you ask someone else to do the same, you have a huge problem. Absolutely. And so you have to have a group that is trained on how to do it. It's very simple. That's the beauty of it. It's not difficult to train. We did a study where we studied the inter-rater variability between the trained researcher, the nurse, and the intensivist. And that's very good. At least in our unit in Rotterdam, it's very good. And so in an experienced population, with trained people, there still will be variability, but it's very minimal. But don't tell your nurse who has no clue what capillary refill time is to do capillary refill time. That's a very good point. You have to be cautious about that.
Yeah, very good statement. Thank you. The next question is maybe a little bit sophisticated. It's about the difference of using, it's coming back to the PCO2 gap. Normally we use the delta PCO2 gap, so the partial pressure of CO2, which comes from every blood gas analysis. But instead of that, maybe we should use the CO2 content difference, like for the oxygen. This has to do with the Haldane effect. Can you comment on this briefly?
Yeah, well, that's an excellent point in the part where the relationship between cardiac output and delta PCO2 is not linear anymore. But in those cases, to be honest, I don't need delta PCO2 because in those cases, from the clinical profile, it's already very clear what the problem is. So if your cardiac output is 1, or your cardiac output is 10 liters or 15 liters, I don't need the delta PCO2 anymore. So in the extremes, it's a very good comment. But in the practical arena, I think more than 90% of your patients do very well with the delta PCO2, capillary refill time, and SCVO2. And it's only the small proportion where, to be honest, intensive care becomes incredibly interesting because the mainstream is we have so much experience now, but the extremes become more interesting, and then let's say incorporating the Haldane effect makes absolute sense.
Okay, that's why I called it a sophisticated question. Thank you.
Yeah.
The next question is, how about B-type lactic acidosis from inotropes like epinephrine infusion?
Yeah, absolutely. There, at least from the studies that were done in France some years ago, where they compared epinephrine and the combinations of dobutamine and norepinephrine. And from healthy volunteer studies, we know that if you use epinephrine, your lactate will go up. Usually not more than to 4 millimoles per liter if you have adequate perfusion, but it will distort your lactate signal. And so that's why I don't like epinephrine. But if you use epinephrine and you don't change the dose, then lactate should not go up any further. So you have an initial change.
Tumors under general anesthesia, we notice an increased lactate, let's say 3 to 4 millimole per liter, which is not associated with hypotension or hypoxia or, let's say, liver failure. What is your explanation for this type of high lactate?
Well, that's a very interesting question because we see the same. We see the same in patients after cardiac surgery, completely optimized off the ventilator, and suddenly they get this surge in lactate. We don't know. It's a metabolic problem. It's not related to tissue hypoperfusion. In the case of cranial surgery, we sometimes thought it was related to sympathetic nervous system activation. Mm-hmm. But if the patient is under general anesthesia, that's very unlikely. In the cardiology patient, it could be stress increases your lactate, severe anxiety increases your lactate. So that could be a cause. But during surgery, those cases are usually very well controlled. Now, the brain is a big consumer of lactate, so maybe the brain starts to, let's say, stress other organs to start produce lactate. That's a very hypothetical suggestion. But we know that, for instance, if muscles start to increase lactate production, the brain will take up the lactate as a fuel. And so I don't have a clear answer, but I think the context that you mentioned, if there is nothing wrong with tissue hypoperfusion, it's probably the other stuff, and the other stuff is very unlikely to kill the patient. And so usually I don't react on it and remeasure and see what the trend is.
And those patients do regularly well after surgery.
Yeah.
Okay, the next question is a more simple one, but nevertheless interesting. So, are high lactate levels always associated or accompanied by a low pH? So, by acidosis? It's lactate acidosis, but is it a must?
Very good question, and related to a lot of confusion. When my fellows and residents talk about lactic acidosis, which is still in the US frequently used, I always tell them that that's an incorrect statement, because what you basically have is lactate associated acidosis, because lactate as by itself doesn't generate acidosis. Because lactate in normal states is completely dissociated, and so in the blood you have lactate minus, but not you don't produce protons. You actually use protons. So the production of lactate is not associated with acidosis, but if you're in a state where your lactate increases due to whatever reason, and especially shock, hypoperfusion, you generate protons from other sources, and that's why the mortality of lactate with acidosis is even higher than lactate without acidosis. And so the combination is a bad sign, but it's not because of the lactate. And in a study that we published some time ago, we saw that let's say the acidosis usually starts when your lactate increases to 5, 4.5, 5 or more. And so in the lower lactate levels, you hardly ever have acidosis. But the relationship of lactate and acidosis is only in the very high lactate levels and due to other causes than lactate.
Very, very clear statement. Thank you. The next question, I'm not sure if you can answer this one. How does the high volume hemofiltration help in improving the microcirculation?
Good question. The theory is, and that's what when I was a resident and a young fellow in intensive care, we used a lot of high volume hemofiltration. The theory we had was that we cleared cytokines, that we washed out bad stuff out of the patient. In some studies, it was shown. In a study in the Netherlands, they showed that if you infuse the filtrate that you got from these patients into an animal, it immediately went into a septic shock state. So we had the impression that we were removing stuff. And in many patients, from our, let's say, subjective assessment, we saw these huge improvements in circulation. When I later on studied the population, we saw that the main effect was rapid correction of pH. And so when we went back to the patient where we started high volume hemofiltration, we saw we usually did it in very acidotic patients. And within an hour, you had normal pH. And of course, then you had normal and more effective vasopressors, and so the circulation improved. I don't think there are studies on high volume hemofiltration and microcirculation.
I'm also not aware of one.
No, so the idea is that you rapidly correct acidosis and filter out especially cytokines. And of course, acidosis and cytokines have effect on the microcirculation.
No. Okay, the next question is let's say more a philosophical one. It's the question of whether lactate itself is a bad thing, or is it just a marker of the severity of the disease state?
Yeah, that's an excellent question, because that's also fuels a lot of misconception. Lactate itself is a fuel, and many cells use lactate as a fuel. And for instance, the lymphoma cells produce lactate. They don't metabolize lactate by itself. Red blood cells do not metabolize lactate, but brain cells and the myocardium are excellent users of lactate as a fuel. And it's been shown in many studies that cells can perfectly survive a very toxic environment as long as if you give them lactate as a source of energy. Remember, if you burn glucose to lactate, you produce a little bit ATP, and the metabolism of lactate to glucose, you need ATP. But if you fuel lactate into the Krebs cycle, you will produce a lot of ATP. So lactate is a perfect fuel. So it's a marker of a bad disease state rather than you are killed by the lactate itself. And that's why studies where they cleared lactate with drugs, dichloroacetate, for instance, all those studies had no effect on outcome. So manipulating the metabolism of lactate won't do any good.
All right, thanks. The next question is, how can we differentiate between L and D lactate in daily practice, and does this matter?
That's a very good question. You can't. So let's say if you look at the patient, you cannot see the difference, but you have to create the context. So the two isomers of lactate have very different origins. And so in humans, we have only, I think it's the L-lactate, and in microbes, the D-lactate. So if you have a patient that had a gastric bypass, for instance, or you have some crazy one that takes a lot of anaerobes in these Yakult drinks, we have seen a few patients that take enormous amount of these Yakult stuff. They start to produce a lot of lactate, but it's from the microbes. So in gastric bypass, and that's, let's say, the clinical condition, in gastric bypass patients that present with acidosis and lactate, but you cannot come up with a clear problem in the circulation, think about the D-lactate of the microbes. Very good point.
Thank you. Then we have let's say, a clinical question that we discussed for as long as I'm in the business. Should we give sodium bicarbonate in lactate acidosis, let's say, due to cardiogenic shock? Yes or no?
Well, it's frequently done, but it has to deal with the acidosis. So if it has nothing to do with the lactate. So if you think that the acidosis is a real problem, and that's basically the basis what I just discussed about this high volume hemofiltration, if you think that this acidosis is really making the treatment of the patient very complicated, then it makes sense to correct the acidosis. And sodium bicarbonate is a interesting way to correct the acidosis. The problem is you also give a lot of sodium to the patient. So the question is whether the sodium or the bicarbonate is the effector. But if you're concerned about acidosis, then there is nothing wrong with sodium bicarbonate. And then you get to the fact, what is a severe acidosis? Well, I think less than 7 is a severe acidosis. Hypercarbic acidosis is, at least from my perspective, not that harmful at all, so I usually don't do anything. But the point is, if you have a very acidotic patient and you can get the heart working again, then I am not that interested in the acidosis. If I cannot get the heart working again, so the circulation basically, Yeah, then I'm usually correcting the acidosis to see if I can make a difference. High volume hemofiltration is hardly used anywhere anymore, so that's hardly an option in these cases. I don't think you can convince any renal physician anymore to start up high volume hemofiltration. So you have to be in control yourself in order to do that. But in those cases, sodium bicarbonate is a good alternative.
All right, thank you. The next question is short, but maybe difficult to answer. Why are lactate levels high in ketoacidosis?
Well, that's metabolism. You have fast glucose metabolism. The glucose metabolism overrides the capacity of the mitochondria, and so you will start to have very high lactate levels in abnormal glucose metabolism, and you have lipolysis. So you start to metabolize lipids where you make your ketones. And so it's a metabolic problem and not a circulatory problem.
Okay. Next question is another clinical, very relevant question. Is there a clinical relevant difference in lactate levels, whether you take it from the arterial or venous or central venous line? Does it matter?
No, not really. If you have extremely poor peripheral perfusion, then the levels may be somewhat higher, because basically if you have an arterial line, you're measuring the lactate that comes from the hand. And so if the perfusion is really bad, it might be a little bit higher. So don't interchange. Don't take one measurement from a finger stick, the other measurement from a venous line, and then an arterial line, and then the central venous line. That's bad. That's not good. But if you stick to one place, the changes over time between the various places are very consistent. So there is no need to prevent venous or capillary. Even capillary, we published studies on capillary as well. But you have to be consequent to use the same place.
Yeah, and comparing papers across the literature, it does not really matter. That's what you're saying.
Yeah.
What they did. Okay. Next question: how much lactate is cleared with continuous renal replacement therapy?
Oh, that's a good question. I forgot the actual number, but remember, most of the renal replacement therapies now use lactate buffered solutions. So there can be a small increase in lactate if your lactate level in the bag is higher than in the system. But again, it has to do with liver function. So you can have a small increase in lactate if you use lactate buffered solutions, but it's never more than 2 to 4 millimoles per liter. If that's the case, you have a problem in clearance.
Okay, thank you very much. In one of your slides, you measured the sorbitol clearance. Is it the same as what I've used, the ICG clearance, the indocyanine gene clearance for assessing liver perfusion?
Yeah, the mechanism is more or less the same. So what happens is sorbitol is metabolized by the liver and is excreted in the same mechanism as ICG, and so it's a transmembrane clearance, and that's why it's closely related to indocyanine green clearance. Yes.
Okay, thank you. Then we have a scenario here. Occasionally, there are patients with an elevated lactate, which is measured routinely, not because of clinical reasons, These patients are not in a hypoperfusion status. They have sufficient diuresis. They are well circulated and are mentally adequate. There is no indication for liver dysfunction, vitamin B deficiency, or drug-related things. However, these situations do occur. Do you have recommendations in these situations?
Well, usually what I do is if I don't understand what's going on and there is no circulatory dysfunction, then I just watch the patient carefully. So be vigilant about the fact that you missed something, and so remeasure. But I have patients, recorded patients, that are drinking coffee and watching television where the lactate goes up to 4, stays at 4 for quite some time, and then decreases again, and no clue. And so if the situation of the patient doesn't change, the patient doesn't worsen, I carefully follow and don't do anything.
Okay. Another more simple question. Can you comment about the lactate pyruvate ratio?
Yeah.
Is it useful?
I mean, from theory, the lactate pyruvate tells you, the ratio tells you whether your lactate goes into the Krebs cycle or not. And so basically, are you, let's say, increasing your pyruvate because lactate is not metabolized to pyruvate and then to the Krebs cycle, and then you generate a lot of ATP. And of course, Krebs cycle abnormalities are related to mitochondrial dysfunction. And so we think mitochondrial dysfunction is related to oxygen. And so if you decrease oxygen, the mitochondria will stop metabolizing, your pyruvate will go up. And so theoretically, the ratio should tell you the same as the CO2 over O2 content. Do I have anaerobic metabolism? Do I have tissue hypoxia, mitochondrial dysfunction, or do I have a metabolism problem just because I burn a lot of glucose? The problem with pyruvate is that by the time you have the number, you should have been done with the resuscitation because labs cannot do rapid pyruvate assessments. We have had some companies interested in doing continuous, just like lactate, continuous pyruvate measurements, but this never came to market. We have it in the brain dialysis, the possibility, because they give you lactate. So you could put a dialysis catheter like that in a vein or a big vein. So in theory, it's great, but we have extremely limited studies that show any benefit. We're currently performing a very physiological study in septic shock patients where we look at delta PCO2, the CO2 over O2 content, the microcirculation, indocyanin, green, everything that we can measure. And in these patients, we also measure the pyruvate. And so we aim to address this question exactly.
Excellent, thanks. Next question is a rather short one and short to answer. What is the best site to access the capillary refill time, the fingertip or the sternum?
Oh, in most of the studies, it's the fingertip and not the sternum. Sternum is frequently used by pediatricians, but we in all the studies we have done, we have always used the finger because we were interested or are interested in peripheral perfusion, and so that's the most peripheral site that you can have. And so we always use the finger.
Okay, thank you. Next question, how to deal with ethylene glycol-induced lactate acidosis? So how to differentiate between fictitious and actual lactate acidosis in this situation?
Well, that's a good question, but that's usually looking at the base excess. You have this extreme weird base excess that's very abnormal when you look at the lactate level. And of course, you have a history in most cases. So you should deal with the intoxication, but not with the lactate.
Yeah. And then there's a question. You mentioned this paper by Jean-Louis Vincent, which also described that lactate could increase after your initial treatment. So could this initial increase after starting a treatment be a good sign of better perfusion of the previously hypoperfused areas, like, for example, the splanchnic region?
Yeah, that's an interesting question. We have studied this in patients during abdominal surgery, where vascular surgery, where we clamped the aorta or had to clamp the aorta. And there is a brief flux of lactate from the muscles when you open up the aorta. So when you reperfuse previously hypoperfused areas. But if your liver function is normal, it's gone within 5 minutes. So there is a reperfusion flux of lactate, but not for 2 hours.
Washout. Yeah, a washout like thing. Okay.
Yeah, but not for 2 hours.
What is the role of thiamine in lactic acidosis?
Oh, that's very clear. If you have thiamine deficiency, you don't metabolize lactate. And so you have this very high cardiac output patient with very high lactates. And so if you see these crazy lactate levels, remember the incidence of very high lactate levels is very low. And so if you have a warm and well-perfused lactate patient with a lactate of 12 and not in severe shock, then yeah, always think about thiamine, because that's it's not very frequent, but it's a very easy cause to treat.
Okay, I think the last questions we have is related to your studies. Why do you only target lactate in the first 8 hours of resuscitations and not beyond that?
Well, that's related to the hypothesis we had at that time, and something that we have now, let's say, proven more or less, is that in those first 8 hours, the likelihood that lactate reflects tissue perfusion is the highest. And so the likelihood that you're dealing with tissue perfusion after 8 hours rapidly decreases. And so if you give a general resuscitation to keep optimizing the circulation, while it's unlikely that the circulation is the problem, then you very likely over-resuscitate the patient. And this is especially true for fluids. Because what I see in many cases is that patients are treated with fluid because lactate doesn't decrease. If you do that until lactate is normal, you always over-resuscitate your patient. And fluid responsiveness has nothing to do with lactate clearance. So to prevent this mixing up of fluid unresponsiveness, fluid responsiveness, lactate increasing, lactate not decreasing, and stuff like that, we said if you give a general recommendation, and that's what protocols do, you should stick with a clear hypoperfusion context, and that's mainly only present in the first 8 hours.
Okay, thank you. So there are still questions coming in. I think we should close, because this is the last questions I would pose to you, and then we close, because we can go on for this the whole evening. This question is, what about lactate clearance in chronic liver disease? How to differentiate this from a patient who is also developing sepsis, or how to manage persistent low-grade lactate acidosis not associated with shock?
Yeah, that's a great question. because we know that if you have liver abnormalities, liver disease, your ability to metabolize lactate is limited. But remember, patients with abnormal liver function, or even patients with end-stage liver function, never walk around with a lactate of 10. So in almost all of these cases, the lactate is a little bit more abnormal than in normal healthy volunteers. And so they're usually at the upper end of the normal spectrum of lactate. And so whenever these patients have increased lactate, they have increased production. You always need increased production, even in liver failure. Now, if you have increased production, they have an even more problem with clearance, of course. So it's very, let's say, frequent that the normalization of lactate in these patients takes much longer than in other patients. But remember, abnormal lactate in these patients is always related to abnormal production as well. So make sure that in these patients you clear the sepsis problem or the hypoperfusion problem or the congestion problem due to right ventricular dysfunction or fluid overload in these patients. But it's a little bit more complex than in other patients, absolutely.
All right. Thank you very much, Jan, again. I think we learned a lot on lactate today. We do have more questions, but I think we should stop here for the sake of the time. We still have much more than 100 participants, but not to stress you too much. I would close it here. I think, as I said, we learned a lot on lactate and perfusion. Today we had some very, very great questions from the audience. So thank you very much for your active participation. Thank you again, Jan, for your excellent presentation and for your willingness to answer all these questions perfectly. I think no question has been left unanswered. So I think it was a very meaningful and important webinar. And I wish you a nice evening or afternoon wherever you are. And I hope to see you again on one of the ESICM webinars in the future. Thank you again. Thank you very much.
Thank you all for your attention.
Bye-bye. Thank you.
Bye.